YouTube as well. Okay, participants are starting to come in, so if you just give it maybe 20-30 seconds, Rob, and then we can.
Okay, will do, yeah.
Thank you.
We'll just give it another 30 seconds or so. I can still see participants are coming in, so just give people time to arrive. Okay, I think we'll start. So I just wanted to start by saying good afternoon to everyone. It's obviously quite weird not being able to see people in the audience again this year, but I can see that there's a lot of people watching, and it's great that there is such interest in this really important topic. Even more vital, I'm going to argue, for this coming winter. So I'm just going to introduce myself and just give a bit of background to the workshop. And then we've got some excellent speakers who are going to give presentations, and there'll be plenty of time for questions and answer and a discussion session at the end, and we'll be due to finish at 3:15. So I hope that's what you're expecting. So first of all, hello, yeah, I'm Rob Howard. I'm a consultant in public health at Leicester City Council. I'm also a trustee of NEA, I have been for the past couple of years. And many years ago, I was also a member of staff with NEA, and I led on the health projects nationally for NEA for a number of years. And that's what actually got me into a public health career. So we go back a long way, and I've been coming back to talk to NEA at various conferences over many years around the issue of health and cold homes. So I'm really pleased to be back. We've had in public health obviously an extraordinary 18 months or so, and it's not stopped yet. I keep trying to get back to my day job and failing miserably as we continue the struggle with controlling COVID. But it has been extraordinary for everyone, obviously globally. But one of the things I think it's shown to me is that if there is political will and determination, we can come together to save lives of vulnerable people. And the amount of effort, the amount of resource, the amount of partnership working that's come together to do that for COVID obviously has been extraordinary. And yet every year, thousands of people die because they're living in cold and damp homes. And every year we struggle to get the political engagement and the resources necessary to deal with what actually is a public health crisis that occurs every winter. And interestingly, the people who are vulnerable from COVID are pretty much the same as the people who are most at risk of cold-related ill health and deaths. And we're talking clearly about older people, people with existing conditions, vulnerable people, people living in poverty, in poor housing. These are the same people who have died in greater numbers from COVID and the same as excess winter deaths. The impact on the NHS this winter of both COVID and also the impact of the NHS just dealing with COVID over the last 18 months is going to be absolutely huge. In fact, the pressures they're seeing now at the very start of autumn is already unprecedented. So it's absolutely critical that this winter we not only protect those who are vulnerable from COVID, but also those that are vulnerable from cold homes, not only for the absolute moral purpose of protecting people's lives, but also to stop the NHS getting overwhelmed. So I think this is a message for all of us working national, regional and local level to work with the NHS and colleagues to see how we can work in partnership to protect people from the effects of cold and damp homes. That's hopefully just set this in context today about this relationship, this long known and quite well understood relationship between cold, damp and health. So we're going to have three excellent speakers, and then there's going to be a chance for you as you're going along or at the end to ask questions in the Q&A box that you'll have access to, and we'll have plenty of time to have a discussion around that at the end. We have a number of speakers. We're going to hear shortly from Craig Harrison from Marie Curie, who's going to be talking about the link between their organisation and their interest in fuel poverty and health. We have Lottie Moore from the Public Policy Projects, or PPP. And first of all, I'd like to hand over to Henry Smith from the Centre for Ageing Better. So over to you, Henry.
Thanks a lot, Rob. Just wait for the slides to load. Thank you. So I'm delighted to be speaking to you all today. We are the Centre for Ageing Better, funded by the National Lottery Community Fund. We are one of the government's What Works centres, so grounded in evidence of people's lived experience. My name is Henry Smith. I lead on our work on housing. We have 4 priority goals on housing, health, fulfilling work, and connected communities. We've chosen these 4 areas because we believe those are the ones that matter the most to people, make the biggest difference to people enjoying a good later life. Next slide, please, Matthew. So I'm going to talk to you today about the outcomes of the Good Home Inquiry, which is an inquiry that was supported by the Centre for Ageing Better, an independent panel chaired by David Orr, the former Chief Executive of the National Housing Federation, Vidya Alexon from Power to Change, Lord Victor Adbawali, and Pat Ritchie, the Chief Executive of Newcastle City Council. And the inquiry looks particularly at the problem that our poor quality existing housing represents, the reason for these and the solutions. We were really clear early on that we didn't want this to be like many inquiries which produce a fantastic list of recommendations based on very sound evidence that then get put on a shelf and not taken into practice. We wanted this to be as action orientated as possible through delivering change with our partners as we went along. Next slide, please. So why the Good Home Inquiry? So around 10 million people live in homes that fail the government's decency standard, which is a shocking statistic. And these homes represent a serious threat to their health and safety. The majority of these homes are lived in by homeowners, but the large proportion by tenure is in the private rented sector. This is of particular interest to us as an organisation because over 4 million of these 4 million homes, almost half are lived in by somebody over the age of 55. In fact, the older you get, the more likely you are to live in one of these homes that fail the decency standard. However, the inquiry looks at homes lived in by people of all ages, the reason being that none of us know for sure which homes we'll be living in 10, 20, 30 years' time. So we believe we need to raise the standard of all of our homes, and building on what Rob mentioned in his introduction about making this crucial link between housing and health conditions, and not least the huge impact that poor quality housing has on our NHS, £1.4 billion a year, which is again really shocking. So what we wanted to do through this inquiry was to really get to the heart of what a good home means to people, moving beyond this rather crude term of non-decency that the government uses. We know we're not going to get all homes up to this good home standard, this ideal standard that we want for every home. But in order to improve our housing stock, we need to know at a baseline level what a good home looks like. Next slide, please. So why a good home inquiry now? Well, COVID, as Rob's saying, has exposed and exacerbated the housing-related health inequalities that we have in this country. And in reality, being told to stay at home during the pandemic has led to people being more exposed to the health impacts of poor quality housing, such as increased exposure to mold and damp. The second reason is demographic change. So we need to make sure all of our homes are fit for purpose. 1 in 4 of us will be aged over 65 by 2041. So we're undergoing this big change as a society, which is, of course, something to be celebrated. But at the moment, far too many people are living in later life in homes that pose a serious threat to their health and safety. And then the third reason is around climate change and the need to decarbonise very rapidly to meet the net zero commitments of the government by 2050. We have to look at improving our homes and improving energy efficiency and opportunities to install heat pumps as well. Next slide, please. So we ran the inquiry according to 4 themes, which are health, energy efficiency, finance, and digital connectivity. We held a series of public webinars, engaged with key stakeholders. We had lived experience as being a crucial part of the research, so understanding the challenges and barriers that people face to improving their homes. And we've also used this test and learn approach with our strategic partners, who are Lincolnshire County Council, Greater Manchester Combined Authority, and Leeds City Council, and using all of that work to implement and influence the work of government. Next slide, please. So I'm just going to say a bit about the underpinning research which we commissioned as part of the inquiry. The first piece was a literature review of the links between homes, health, and COVID that we commissioned the King's Fund to do. And this found that COVID has exacerbated inequalities. We've found out that people who live in poor quality housing were more likely to suffer from the serious implications from COVID due to 2 reasons. First, because of that increased exposure to poor quality housing and respiratory issues that they have. And the second, the likelihood of people living in overcrowded homes and increasing the transmission of COVID. Some of the statistics that we found during the literature review includes that 1 in 5 excess deaths during winter are attributable to cold homes. For every £1 that's spent on home improvement services to reduce falls can lead to savings of £7.50 to the healthcare sector. And every £1 that's spent on improving warmth in homes occupied by vulnerable households can result in £4 worth of health benefits. So there's this clear economic as well as individual case for us improving our existing housing stock. Second bit of research was with Ipsos Mori, which is about the challenges and barriers that people face to improving their homes. We found as one of the major findings that people often don't make the connection between the quality of their housing and their health conditions. They also don't trust tradespeople on the whole. They rely more on advice from friends and family for support. And they don't know where to go to for information and advice to improve their homes. The next bit of work we did was a poll, which found that finance is the biggest barrier to people improving their homes, access to finance, the fact that many major lenders don't offer small loans. The interest rates are often far too high and people worry about financial security and the impacts in their later life if they make a decision to invest in their homes. The next bit of work was with the Centre for Collaborative Housing Excellence, which was a policy review looking at past successes and failures in government policy and the impacts of present policies. And the main finding for this was that we've had underinvestment in the last couple of decades, which has led to a serious set of issues with our existing housing stock. And the work came up with a series of policy interventions, including home MOT, government-backed loans, and the idea of a good home agency, which is a kind of a home improvement plus approach. We see that there are many home improvement agencies that operate very effectively across the country, but it's very much a postcode lottery. So in many areas, they don't have this access to local information and advice and trusted tradespeople. So we want to see a much better network of these across the country. And then finally, with Britain Thinks, which were a series of public dialogues testing out some of these policies and getting the public's reaction to them. The reports are available for all of these and happy to circulate them afterwards. Next slide, please. So our key findings from the inquiry have been that we don't have ownership of this problem of our existing homes at a national level. We need a longer term approach than we have at the moment, such as seen from the issues with the Green Homes Grant and other interventions that don't take this longer term approach to improving our housing stock. We need to be thinking more holistically about investing and improving in our homes. We need local hubs that reach homeowners. They're a very difficult group to reach. There's not the same institutional support as there is, for instance, in social housing. And we need a more comprehensive mix of financial products to be supporting people to improve their homes. Next slide, please. It's getting towards the end, you'll be glad to hear. So our recommendations are fourfold. The first, that we need greater national leadership through a cross-government housing strategy with a ministerial champion to implement it. Looking at a local level, as mentioned, we believe we need a good home agency in every local area, which provides access to information, advice, finance, home repairs, and helps with this tailored approach that local people need. Thirdly, we need a combination of government and private investment to develop financial products that encourage and incentivize homeowners and landlords to improve their homes. And lastly, that we need inclusion of housing as a key part of preventative health strategies, thinking about opportunities through integrated care systems and other parts of the Better Care Fund. Next slide, please. So finally, taking forward the Good Home Inquiry and what we're going to be doing at Ageing Better, and what we'd be really pleased to get your support and look for opportunities to be working with everyone on. Next slide, please. So there are three main areas that we're going to be focusing on. The first is around the concept of a good home agency, which can take its form in a variety of different ways. We're not wedded to a particular model, a particular name. In many cases, it will be building on what exists in local areas. In some cases, establishing new hubs and centres where people can access information. But we believe there needs to be a national network of these agencies. And so we're testing out a new approach with our partners in Lincolnshire County Council to provide this, this one-stop shop, as they're calling it. The second is around new models of finance. So working with investors, lenders, consumer groups to test out models of what would appeal to homeowners and landlords to access the finance they need. And then finally, looking at the demand side of things. So providing guidance to people in greatest housing need on what resources and support are available to them, and informing decisions about moving home as well, to make sure that those decisions help them to live fulfilling later lives. So that's it. I'm really happy to take any questions, which I understand we're going to be having at the end of the session.
Thank you, Henry. That was really fascinating, and really impressed with the broad base of all the different research projects coming together into that one report. I'm just going to ask a quick question, because it's specifically about some of those reports. I just wondered if there was there any opportunity to do any engagement with the health sector, and particularly this issue of trying to get the health sector to identify those most vulnerable people for further help, working in collaboration with local authorities and others. And wondered if you did, if any of those reports had an opportunity to do any of that.
Yeah, that's a really good point. And one of our, I guess, key aims was to engage more with the health sector and make sure that this link between housing and health is made more strongly. So one of our partners in the work we were doing was with Care and Repair England, who lead on the housing and health group, and have this access, I suppose, to people in most housing need and how they access services at the moment, making sure that, again, these opportunities with integrated care systems are made. We've had conversations with NHS England and others about their views on where the kind of crucial access points are for people in the system, where people can be helped to improve their homes. So it's a key part of our work moving forward, is strengthening those links in services. That's
great. Thank you very much. Really interesting presentation. So we're now going to move on to Craig Harrison from Marie Curie, who's going to be talking about the links between Marie Curie and cold homes, and in particular a report around terminal illness and cold homes. So I'll hand over to Craig.
Yep, thank you very much indeed. Rob, can I just check that you can hear me okay before
I can hear you. I can't see your picture at the moment.
I launch into it? Oh no, you're not missing anything then, don't worry about that. Yep, thank you very much. As Rob said, my name's Craig Harrison, and I make up part of Marie Curie's policy team. Now you could probably tell from the funny accent that I'm based in Northern Ireland, but I have a role in Marie Curie's work when it comes to fuel poverty policy across the UK. Now, I suppose as a provider of hospice and end-of-life care, you may have seen our name on today's agenda and maybe wondered if you'd registered for the wrong event. I promise you haven't. And hopefully what my presentation is going to show is that not only is fuel poverty a major issue for many terminally ill people and those at the end of life, but they may even be one of the groups who are hardest hit by the morbidity and mortality that's associated with cold homes. So for the next few minutes, I'll just look at some of our research into that area, what the causes and drivers are, as well as some potential solutions. So I suppose it's well recognized that some of the most vulnerable groups to the impact of fuel poverty and cold housing are older people, people with long-term health conditions, and people with low or declining incomes. But I suppose what is important to recognize is that many people who are terminally ill or at the end of life fall into most, if not all, of those categories. Now, we don't collect official data on fuel poverty prevalence among this group, but when Marie Curie surveyed our community nursing workforce last year, nearly a third of those who responded to that survey said that they'd cared for a dying patient within the last 5 years who had struggled with their heating costs. And beyond that, I suppose we know that people with a long-term illness or disability make up a significant proportion of fuel poor households in England. And through the work we have done on this, we've identified two primary drivers for that. So first of all, there's a number of connections between the physical effects of different chronic or terminal health conditions, feeling colder, and consequently building up higher heating bills and fuel costs. So for example, people with cancer will often lose weight and have reduced energy levels. People with neurodegenerative conditions like dementia, the symptoms of that will often restrict their physical activity and slow down body heat generation. And all of that can make someone feel colder and require the heating to be on for longer. More broadly, I suppose people who are terminally ill are more likely to spend more time at home than average. And especially as their condition deteriorates and they approach the end of life. And what that means is it increases both the need for their house to be heated for longer, and I suppose, and the risks to their health if they can't afford the resulting high heating costs. Now, interestingly, when we asked our nurses about this, we also found that the symptoms of some conditions can lead patients to take steps that inadvertently make their living environment colder. So for example, people living with conditions like lung cancer or COPD will often experience breathlessness. And to help mitigate the symptoms of that, they may open the windows in their house. Even if the temperature outside is quite cold, they may open the windows in the house because it helps to mitigate the symptoms of that. And the impact that all this can have on a dying person's fuel costs can be absolutely massive. So for example, people with cancer were estimated to have spent nearly £16 or £16 million a year more on energy bills between 2014 and 2016. And other research into people with motor neuron disease found that their average energy bills nearly doubled after their diagnosis. Now, unfortunately, many of the people I've described face these growing energy bills at a time when they can really least afford them. I suppose, to put it very bluntly, it can cost a lot of money to die in the UK today. So Marie Curie's estimate is that around 2/3 of households affected by terminal illnesses experience financial strain as a result. And what that means is that at the same time as many of these people are facing significantly higher heating bills, their financial resources are also seriously depleted due to the effects or the other effects of their health condition. So for example, they'll often have to pay for expensive equipment and home adaptations so that they can remain in their home and enjoy good quality of life, and as well as facing additional costs for things like specialist food and travel for medical appointments and higher phone and broadband bills. And we estimate that these latter costs alone could be as high as £3,300 per person per year. And the cost of home adaptations, of course, could be several times that again. So beyond that, serious illness is obviously a big barrier to employment as well, not just for the person themselves, but also those who live in the house with them and their carers. So in many cases, the income of the whole household is affected while they're trying to meet these additional large costs as a result of the person's illness. And in the context of all those financial pressures, social security and state support can be a real lifeline for someone who's terminally ill, who's living in fuel poverty. So for example, we estimate that as many as 60% of terminally ill people rely on benefits as their main source of income. But there are far too many who are missing out on what they need, because of issues and flaws within those systems. And I'm going to come back to some of those points in more detail when we're looking at solutions later. But these drivers, unfortunately, combine to create what Marie Curie refers to as the vicious cycle of fuel poverty and terminal illness. And that's where the deteriorating health of someone means that they have to spend a lot more to heat their home sufficiently, which some people can't afford because of the high cost associated with their condition. But the consequences of living in a cold home can be devastating and really cause their health and well-being to get even worse. So whether it's new infections, the worsening of symptoms like pain, a greater risk of falls, increased rates of admissions to hospital, and decline in mental health. What our research showed is that these are just some of the direct impacts that fuel poverty and cold housing can have on a terminally ill person. And I suppose that's, oh dear, what have I done? There we go. That's made all the worse by the fact that their health is already declining. So if something like an infection could have maybe only a minor impact on an otherwise healthy person, the impact can be really devastating if you're already dying and coming towards the end of life. I suppose, and in the worst cases, the impact can even be fatal. So when I mentioned that nursing survey a moment ago, nearly a fifth of the nurses who told our survey that they cared for a patient in fuel poverty believed that it hastened their deterioration. And that's very much borne out if you look at the wider excess winter deaths data. So there's just a few examples here, but to look at the dementia statistics, since 2010, between 5,400 and 16,100 excess winter deaths from dementia can be attributed to cold housing in England, depending on whether you use the 10% or the 30% calculation. And that's actually, regardless of which one you use, that represents a 142% increase since 2001. And the numbers for respiratory disease deaths during winter are similarly very scary. So I suppose on the whole, terminally ill people may not only be more susceptible to fuel poverty than many other groups, but they're also at a much greater risk from the health consequences that's associated with it. So what can we do to tackle this? There aren't any silver bullets, unfortunately, but we would put forward a few different suggestions and ideas to try and tackle fuel poverty and make energy bills more affordable for people at the end of life. I don't think there's anywhere else to start other than with financial support. We should always remember that what fuel poverty has in common with food poverty and water poverty and clothing poverty, etc. They're all born from poverty. So to start with, we need to see major changes to the social security system so that we can help provide DAM people with the financial support they need for things like their energy bills. So at the highest level, the combination of ending the universal credit uplift at the same time as we're in a situation of rising energy bills is just a recipe for disaster. Ending that uplift is expected to leave around 6 million claimants £1,000 worse off annually. And that amount, when you look at the data, is actually 5 times as large as the average fuel poverty gap that's projected for England this year. So we really need the government to keep that particular lifeline. Now, that isn't I suppose, the only major issue with the UC system. So, for example, terminally ill people who, I suppose, by their very definition, don't have a lot of time left, are still subject to a 5-week wait for their first UC payment, and that has been shown to push people who are in a tight financial spot already, not just into worse debt, but potentially destitution as well. So one way to help mitigate against that would be by, for example, changing advance payments of universal credit from repayable loans to non-repayable grants. Now, along similar lines, it's also really important that reforms to the special rules for terminal illness in benefits law are delivered quickly. That system is supposed to allow down people fast-track access to Social Security, but the system isn't fit for purpose. Now, DWP have promised changes to that, and we need to see those changes that come in sooner rather than later. To look more specifically at, I suppose, energy related programs, the support provided through the likes of the Warm Home Discount and winter fuel payments can make a massive difference to people who are fuel poor, but arguably they're both too orientated around someone's age and probably not responsive enough to underlying need among younger people and other vulnerable groups. So it's to be welcomed that the department is consulting on the future of the Warm Home Discount, and what we have advocated for is that the criteria for core group 1 could be widened to include all low-income people claiming relevant welfare benefits through the special rules. And similarly, a new vulnerability component could be added to the eligibility criteria for winter fuel payments, so that people who are non-pensioners can benefit from the support that it provides. Just very quickly before I wrap up, we need to look beyond, I suppose, direct financial support to how we can better link health and social care providers with the housing sector, as the title of the fringe suggests. And I suppose the good news is that we already have a head start on one of these. That comes in the form of NICE guideline NG6, which I'm sure everyone's familiar with already, but it relates to excess winter deaths and the health impacts of cold housing. And in the context of what we're discussing today, recommendation 2 is especially important because it recommends that health and wellbeing boards provide tailored solutions to fuel poor households via a single point of contact health and housing referral service. So that's a great recommendation, but the problem is it isn't being implemented universally. So last year, Marie Curie sent a series of FOI requests to all health and wellbeing boards in England, and among those that provided information back, less than 60% said that a single point of contact service or something similar was in place in their locality. Now, that delivery rate has improved over the years, but it still isn't universal, so we need to see that universal implementation. And just finally, we also think there's work to be done when it comes to meter switching. So earlier this year, the IPPG on terminal illness in Westminster carried out an inquiry into housing and fuel poverty among people at the end of life, and it found that many people in that situation may struggle to switch from the more expensive prepayment meters to the cheaper credit or smart meters because of issues like the requirement for debt to be settled or the requirement for a credit check. So we think we need greater flexibility, I suppose, in compassion within that system. As I hope I've demonstrated, a lot of terminally ill people find themselves in quite a tight financial spot, through no fault of their own. No one chooses to face those high extra costs. So we need more flexibility and a recognition of those factors to help prioritize people who are at the end of life for meter switching. I'll just leave it there, I suppose, just with a final comment that, the measures I've outlined will cost time and they will cost money. But I suppose we have to ask ourselves, are we willing to put up with a terminally ill person being robbed of a good quality of life, or being denied, precious days and weeks that they could have with their loved ones because their energy costs are unaffordable. That's the reality facing some terminally ill people today. And I'm sure everyone would agree that that's simply unacceptable. So thank you very much. I'll leave it there, Rob.
That's brilliant. Thanks ever so much, Craig. I mean, that's really, it's quite emotional, really, and particularly if people got a chance to read some of the quotes from some of the people that you talked to. They were really very moving, and you're not quite sure whether to feel desperately sad or really angry that people end up in this position, and the fact that a third, I think you said, of terminally ill people struggling with their fuel costs is really quite a shocking indictment of this. And I think talking about death and terminal illness is it's such a taboo subject still, isn't it? It's one of the remaining taboo subjects. But we're all going to die. We're all going to, we're all going to be there at some point, and the thought of being there and still struggling with, the basic necessities of life is just really, really shocking. So, thank you for highlighting that, for those research, but also for them. I think there's some really practical recommendations and so on that you've put forward there, which I know there's some good questions coming in already. So we'll return to those at the end of the session. But thank you very much. And finally, I'd like to hand over to Lottie Moore, who works for the Public Policy Projects, and in particular is going to be talking about a report around tackling health inequalities from outside of the health sector. So Lottie, over to you.
Thank you, thanks. Can you hear me all right? Just checking.
I certainly can.
Yeah. Good, great, lovely. And I apologise. My slides are sort of less glamorous than the two previous participants. So, anyway, well, thank you so much for having me, and I'm delighted to be here. So, first off, I'll tell you a little bit about Public Policy Projects. So, we're an independent policy institute think tank that's based in London, and we produce policy primarily in the space of health and life sciences. So, I came on board in January of this year to really open up and lead a social justice and health programme. And what we do is we get people together who really know about the issues that we want to talk about and ask them questions and write up reports with tangible policy outcomes. And we've produced this particular piece of work, which I'll be talking about, on health inequality with the Institute of Health Equity, which you may know is a research unit based out of UCL and is led by Professor Sir Michael Marmot, who's been spent the last 40 years talking about health inequality. So I thought I'd just give you some basic statistics on health inequality. So from 2011, increase in life expectancy begins to slow after centuries of improvement. From 2019, life expectancy has halted entirely. And in the most deprived areas of the UK, it's reversing for women. And there's at least a 10-year gap in life expectancy between people in the most wealthy areas of the UK and those in the most deprived. And the gap in what we call healthy life expectancy is as much as 2 decades. So healthy life expectancy means living in good health. So people in the most deprived areas will live 20 years less in good health. And obviously, what has COVID done to this? So we've had the sharpest fall in life expectancy since the Second World War, which is expected across the board. But what it's done to health inequality has been quite devastating. Between March and July of 2020, so the first wave of the pandemic, a male living in the most deprived area of England was twice as likely to die from COVID-19 than his equivalent in the least deprived areas. And I know obviously that the previous participants have touched upon this link. And so, in the United Kingdom, I think the point is that we've been entitled to think that health is continually improving, that society for our children will be better than society has been for us. And once we recognise that life expectancy is declining, that isn't an illusion that we can hold on to anymore. So we can't say with confidence that a baby born in 5 years' time will live longer than a baby born next year. And so what does housing have to do with health? Could I have the second slide, please, Matthew? Thank you. So the Institute of Health Equity have set a policy agenda as to how we tackle health inequality. Michael Marmot was commissioned under New Labour to do an assessment into health inequality, and that was published as the Marmot Review in 2010, just as David Cameron came into power. And the review was centred on the social determinants of health. And so what are the social determinants of health? Well, we refer to them as the causes of the causes. So, for example, why is it that poorer children have higher rates of asthma? Because they are more likely to live in housing where conditions are cold and damp. And so social determinants refers to housing, education, employment, family breakdown, the justice system, to name but a few. And so when we're talking about the social determinants of health, we're talking about the causes of the causes. And Michael Marmot's book that's published in 2015, which I recommend you to read if you're interested in this subject, is why treat people and then send them back to the conditions that made them sick. And so 20% of a person's health outcomes is dependent upon the healthcare they receive. The other 80% is accounted for by the social determinants of health. So if we believe solely that health is something that should be provided for by health systems, what we're doing is we are medicalizing a problem that has social causes. And the strength of the NHS as a kind of unifying national idea is such that we always sort of tend to believe that health is something that can be delegated to the NHS. And Duncan Selby, who's obviously Chief Executive of Public Health England, he said, if you give someone a job, a friend, and a home, you will do more for them than you can do in a white coat. And again, World Health Organization, the social conditions in which people are born, live, work are the single most important determinant of good health or ill health, of a long and productive life or a short and miserable one. And in the UK, we are not doing well in terms of health inequality. And I would go as far as to say that health inequality is an embarrassing stain on a nation that has one of the best health systems in the world. And so where does PPP come in? So could I go to the next slide, please, Matthew? Thank you. So addressing the national syndemic, and I'm going to explain to you the title. So a pandemic, as we all know, familiar with the word by now, refers to all members of a group experiencing the same disease. A syndemic best describes two or more diseases that synergize to make each other worse. And the diseases of discrimination and disadvantage within health existed long before the coronavirus. And yet the pandemic has exacerbated health inequality to such an extent, which is why we called the report Addressing the National Syndemic. And so we hosted a series of roundtables with experts from across local government, the public services, the NHS, business, and the third sector. And when I say expert, I also, as Henry referred to, people with lived experience. You know, who do we consider the experts? People that are sat like us in ivory towers, or do we consider the experts the people that know about poverty because they're living with it every single day of their lives? And so what we found is that there has been a lot of action locally, and this has been accelerating in the context of pandemic. So local governments over the past 10 years have really been driving change. And while there's been no tangible national health inequality strategy for over a decade, it would be a mistake to think that people are not interested in this issue. Action is happening at local level, and that is really important because, well, you need national government to be interested, because national government has to have a national narrative, and that narrative plays an important role in creating the conditions and the capacity for local players to play their part. But actually, when you have action at local level, at community level, this is brilliant because you're making a change where people are actually born, living and working. And, you know, action might have been stagnant at Westminster, but it's been thriving in local communities across the UK where people are actually living their lives. And if enough local areas around the UK begin tackling health inequality, we argue that national governments will be under significant pressure to respond. But the central point of our report is that action on health inequality cannot just come from one place. It can't just come from local government or national government or the NHS or the third sector, who all have a crucial role to play. Each of these stakeholders need to be working together. And the central point is that if we're going to talk seriously about the causes of the causes, action needs to be coming from people outside of the health sector. And what we found has been amazing and uplifting. And there are people and systems and structures, much like the NEA, that are tackling health inequality without even necessarily realizing that that's what they're doing. Because as a social determinant, obviously the link between housing and health is inextricable. And so we're arguing that the best way to tackle health inequality is to take a cross-sectoral approach. Local governments working with public services, businesses in the third sector, and community voices have to be at the centre of that. And so I'm just going to briefly go into the kind of role that each sector we suggest each sector should play. And so firstly, local government, we found that it's the best place to land a health inequality strategy because it does have the levers, partnerships and systems it needs to influence others' public services. And the strength of local government is really in the local bit in that, you know, they know the lay of the land better than anyone else does. So what will work in London will not work in rural Cornwall. What will work in one London borough won't work in another. But the key is that you've got the right people in the room to know that. And Wigan and Gateshead are two brilliant examples of this. Both of those places have reversed declining life expectancy over the past 5 to 10 years. And they've done that at a time of unprecedented cuts to their funding. In terms of other public services, you know, we actually had teachers and policemen and nurses coming to our roundtables. You know, you need people, basically, any organisation that interacts with the general population should have an interest in their health. And it's not simply a case of different health sectors building health services into what they're doing. It's recognising that health has very little to do with health in and of itself, and much more to do with wider social, economic, environmental factors. And I think the key message has got to be that health inequalities are damaging for everyone. Health inequality should be embedded in any public service strategy, because inevitably that public service will impact health in some way. And again, with the NHS, the core mission of the NHS is to deliver healthcare to populations, including those that are undeserved. It is not clear that it is the mission of the NHS to tackle the social determinants of health. And I think, as I said earlier, in the UK, we have the NHS as this kind of unifying national idea. When the NHS intervenes in a local community, it tends to do so with substantial more resource than other public services. And one of the consequences of that is that the importance of individual places can be undervalued. And so what we're arguing is that the NHS in and of itself is important, but the NHS must also work to find its role within a wider network of whole sector approaches that tackle the social determinants. And it shouldn't be assumed that just because the NHS is involved in this partnership and we're talking about health inequality, the NHS should lead this network. Rather, the NHS needs to become more aware of partnerships. And really then we've got the third sector. So we found that the third sector often works to support those that are most excluded and at risk of poor health, as well as having long-standing relationships with the local communities. So support and advocacy on behalf of communities is essential to improve health, even when the focus isn't on health itself. And despite the positive context, collaboration between the third sector and other sectors has been limited by lack of capacity and kind of funding issues. Despite these constraints, there is a wealth of evidence to suggest that successful action to reduce health inequalities is there by the third sector. And again, really important in terms of co-producing services. And finally, the business sector. The private sector has become more interested in health inequality as a result of the pandemic. Over 80% of people who are employed in the UK are employed in the private sector. And to suggest then it is the role of the public sector to look after those individuals is entirely false. There is a great potential for businesses in the UK. There is millions of pounds worth of corporate social responsibility that currently is untapped. And in many cases, what we found is the private sector is looking for direction. They just don't know where to begin. And so, yeah, that's our health inequality report that we're launching with Michael Marmot on Monday at the Conservative Party conference. So I'd love to share it with you all, and thank you very much.
Thank you so much, Lottie. That was absolutely fascinating. I'm sure a career in public health awaits you. But that's, yeah, really fascinating. I mean, particularly the analysis around the changes in life expectancy. My concern about that is that it'd be very easy to use COVID as an excuse for that. But actually, the life expectancy had already started stalling before COVID hit. So back in 2019, it was pretty much stalled, particularly for females, and in many poorer areas had already started reducing after getting on for 10 years of austerity, and those changes to those social and wider determinants of health had already kicked in, and they were having that fairly dramatic impact on life expectancy that we haven't seen for decades. And that's really quite stark. And I think it's, we need to make sure that it's not, obviously COVID's had this massive impact, but it's not only COVID that's making that difference. But that was really fascinating. I was quite jealous of you working with Michael Marmot, who's clearly, obviously a public health hero to us all as well. Thank you to all the speakers. That was absolutely brilliant, and really quite a kind of wide range of different issues that you've investigated and explored with us today as well. We have quite a few different questions coming in, so I'm going to start going through those. I don't know if we'll get through all of them, but I'll start with a question which was, I think it was aimed at Henry, but it's probably relevant to everyone really, which was, of the research that you've been doing, have you uncovered any evidence or good practice examples around joint working across health and housing sectors to enable the implementation of the NICE guidance on cold homes? So I'll start off with Henry, I think, as you started first, and it was aimed at you.
Yeah, so there's one really inspiring example that we learned about, which is, I think, building on what Lottie's just mentioned about engaging with organisations locally who you wouldn't think typically as being responsible or engaged in the health sector. So the examples in Derby City Council, which is their Healthy Homes Hub. It's really worth knowing about, and there's a case study written up in the final report of the inquiry, which I'll share. So the hub is, it builds on citywide partnerships that exist already, so including hospital discharge teams, the ambulance service, occupational therapists, GPs, the fire service, the police, and also community groups. As part of the council's Better Care plan, Better Care Fund plan rather, and it identifies particularly vulnerable residents whose homes are putting them at risk of poor health, and increases access to these individuals who don't currently access and engage with health and council services. So it's supported in the council, the city's joint strategic needs assessment and health and wellbeing strategy. So a really good example of this kind of cross-departmental work, and it being embedded at a strategic level, which is what is really needed, and what we're quite clear about from the inquiry is the need for this ownership at a local level, at a strategic level. So yeah, it's been really instrumental to reduce delay and lessen poor health outcomes, and there's some pretty stark statistics as well about how many people have been helped who wouldn't have done otherwise. So yeah, do read up about the case study.
Yeah, that's great. That's really good to hear. And the Healthy Homes Hub, I can't remember what it's called in Derby, they're friends of NEA and have been to previous conferences and so on as well. So it's really good to hear that their work has been picked up on. Craig or Lottie, do you want to come in with any further information around this kind of practical link between health and housing?
Yeah, to be honest, because we were trying to collect information on quite a few of the recommendations from pretty much every health and wellbeing board in England. I can't sort of recall that level of detail, but I suppose it is important to note. I focused on my presentation on the proportion of health and wellbeing boards who haven't implemented the single point of contact health and referral service. There are also a lot that did, and they should be credited for doing that. I suppose that the real take-home point from my point of view is that what we discovered is perhaps a bit of confusion among different groups as to who was responsible for implementing which recommendation. So for example, when it came to a few of them, you could have in the same area the CCG coming back and saying that's the responsibility of the local authority, and the local authority saying that's nothing to do with us, it's the responsibility of the CCG. So maybe there's a bit of work to do. Certainly there's a lot of localities that are doing some of this really well. Clearly there's a lot of progress still to be made, and maybe we can help to do that with perhaps a bit more communication and a bit of more clarity among those different actors as far as who is responsible for what is concerned.
Yeah, that's a really good point. I mean, certainly in England, we have the emergence of the integrated care system, and the whole idea around that is those different sectors coming together and having joint outcomes, pooling budgets together and so on. I think there is potential through that. And I think it needs the people in this audience to be actually getting involved in those and making sure that this issue is on their agenda. Lottie, did you have anything to add, or should we move on to another question?
I would just second what you've said, Craig. There, I think what we found is in trying to create this network that actually you don't always have the right people talking to each other, and often responsibility is deferred. And I think it's key. Communication is key, and actually, in order to have kind of good collaboration, you've got to create a space where that is possible, rather than people working in silos. I think is a huge issue.
Lovely, thanks, Lottie. Yeah. I'm going to move on to another question. We've got one close to my heart, working in a local authority, which is about, it says, given the local authorities have been badly affected by austerity, and yet it will mainly be the NHS which sees any financial benefit. I'm not sure whether they'll see much financial benefit, but I know what you mean with that. How can we build the case for financial benefits which accrue to the councils directly? So I think the general question is, what tends to happen is the NHS is untouchable in terms of budgets. Whether it gets enough is a different question. Local authorities are an easy target, and yet local authorities in the voluntary sector are the ones that have that ability to influence and work on those wider and social determinants of health. So I guess it's what messages, and I'll start with you, Lottie, as you're on the screen. Start with you about thinking from your work, from the examples that you saw. I think you mentioned, was it Wigan that you mentioned about the areas that managed to improve life expectancy? What do you think the key messages are from those examples around how to make this go up the political agenda and actually direct resources at it?
Yeah, no, I think it's interesting because, as I said, the councils that we've worked with reduced health inequality at a time when they've never had so little funding. And there's a brilliant analysis of the Wigan deal, what was known as in Wigan called the Wigan deal by the King's Fund, and I'd really recommend you to read it. And it outlines really, I can find a link to it, but outlines sort of brilliant recommendations analysing what they did and why it worked and how it worked. But basically, what Wigan did is they called it a community deal, a kind of deal between businesses, the local authorities, public services, and everyone was encouraged to be part of the deal. And really, it was a commitment to reducing inequality despite these public funding cuts. And I think good leadership, charismatic leadership, is a real key. Local authority charismatic leadership, being able to say in a room where you're not necessarily wanted, where a public health person is not necessarily, what are you doing here? That actually, everyone should be caring about health inequality. I think that's the message. But I agree with the sentiment of what you're saying. It's not easy.
Henry, did you want to come in on that point?
No, I think just to, firstly agree with what Lottie's saying about the difficulty of achieving that kind of local buy-in and the importance of leadership. I think for us, it is about delivering on other priorities as well and taking this holistic approach. So thinking about the decarbonisation agenda and the number of councils who have declared climate emergencies. Many of them have set really ambitious targets much earlier than government for improving their housing stock. And so, that is a huge opportunity, I think, when you're decarbonising housing, to also go in and make many other changes addressing hazards that people have in their homes. So yeah, it needs that holistic approach. It needs to be thinking about, what are the objectives across different departments, and how can you be meeting those? And the financial bit is tricky, but I think it sort of gets to the heart of making services more efficient, and using the resource constraints at the council to really kind of push that message forward.
Thank you. Craig, did you have anything to add to that? If not, I've got another specific question for you.
Oh, yeah, yes, sure. Far ahead with that, then.
Someone's just asked about whether they are able to link in with the local Marie Curie teams to offer support from the local care system. Do you have local reps and teams that people can link with?
So I'm not 100% sure I understand the question, but if Yeah, certainly, the Marie Curie community nursing workforce is that's where they are. They're out there on the ground, and obviously we have bases in 9 hospices across the UK as well. So certainly, we try our best to link in with other services. There's definitely more work to be done, and I think maybe even within our own organisation, a growing recognition of the impact that some of this sort of stuff can have. And I suppose the easiest way to describe it is, when we think about someone coming towards the end of life and what shapes their end of life experience, the best doctors and nurses in the world can't make up for the fact that you can't afford to heat your home or you can't afford to put food on the table. They're all so interconnected. So there certainly is an awful lot more work to be done, I think, to link those various different bits of the system. And I suppose that's, that is the topic that we're here to discuss today.
Yeah, I think people would. I mean, is there a website where people can get hold of local representations of the organisation? I think that was the question.
Oh, sure. Sorry, yes, I've completely misunderstood that. I suppose it would depend on where they're coming from. If it's from health and social care professionals, certainly they can link in via hospices and our telephone referral services.
There was just one from me as well while you're on, which was. You talked a lot about in some of the recommendations around, quite a wide range of things. I wondered if you came across any examples where actual improvements to heating and insulation measures were prioritised for people who were terminally ill, and whether that should be a recommendation.
Yeah,
I know it's quite tricky because if it's disruptive and so on, that might be not what people want, but it's an opportunity maybe.
Well, certainly, and I think this is one of the points you touched on in your opening remarks, and it almost links back to one of the previous questions about the financial impact. I really don't think we're doing enough to raise awareness of just how much it costs, whether it's local government or national government. The health impacts of this and the cost of that is absolutely huge, whether that's, increased use of GPs or hospital admissions and that sort of thing. I couldn't touch on a specific example to mind at the moment, but it's maybe a good opportunity actually to mention that Marie Curie and NEA are hoping to do a further piece of research together over the next 6 months, looking at more specifically how those recommendations and the NICE guidance are being implemented for people at the end of life and what the sort of impact of that has been. And I will be quite confident that if we can get that project off the ground, there would certainly be a lot of good practice examples that sort of come to light under that microscope.
Fantastic, thanks very much. That did answer that question. That's great. I think I'd like to kind of finish off the discussion with getting your thoughts on what you think the top priorities are over this next few months, particularly in relation to this coming winter, and bearing in mind some of the stuff we've already talked about, the links between COVID and cold homes. What do you think people's top priorities should be to both identify and prioritise the most vulnerable, working with various sectors? So from your different perspectives and from your research, where do you think people would be best focusing their efforts? I'll start off with Lottie.
That's a really good question. Thank you. I would say that it's got to be, asking national government, what on earth are they doing? People are dying because they are poor and cold, and it's 2021 and we can't have that. So I'd say people, write to your MPs. Maybe it's a bit of a simplistic and naive response, but that's what I'm kind of tempted to say.
Yeah, no, I think that's very good, and I think it was kind of what I was alluding to in the introduction, is the fact that we have seen that when there is a political will, and I mean obviously it's caused by this huge global crisis, but when there is a political will, there is the ability to take action, to put resources in to save people's lives. And I think there are some lessons from that whole experience taking forward in terms of tackling cold-related deaths and ill health as well. Henry, what do you think from all your research would be the top priorities for people here to take forward?
So as well as this big wake-up call that government needs, which I think is absolutely right, I think it is about, especially in the run-up to COP26, about making the link between people's health and opportunities through the decarbonisation agenda. And we're likely to hear a lot more about that. It feels like that's not urgent enough as a response. So I think it is about using those local networks that we know work and making the case for them to be built on in order to help those who are most vulnerable. And particularly what we found out through the work of Lincolnshire is kind of really making sure that we get this cross-departmental buy-in about the importance of tackling fuel poverty and helping those most in need. So I feel like we kind of need more champions. It comes back to this point about leadership. We need more champions for this case at a local and regional level to be really pushing the agenda.
Thanks, Henry.
So it's not one answer, it's about 4 or 5, but
that's all right. That's all right. That's fine. Craig, final word on this to you.
I think I would just stick to a theme that I mentioned during the presentation. When it comes to that NICE guidance, not just the recommendation I focused on in terms of single point of contact services. There's an awful lot of stuff about what health and social care professionals should be doing, during the hospital discharge process, for example, during the discharge assessment process. There's a recommendation there about annual checkups on patients who have been discharged to check on things like their heating requirements and the standard of their home. If we had 100% compliance across all those recommendations across every locality in England and Wales where the guidance covers, you could identify an awful lot more people who have been living in fuel poverty, and you could signpost them and give them an awful lot more people the support they need to get out of it. So it's really, those recommendations are there for a reason. We don't need to reinvent the wheel. There is a great framework there that's just implemented to the fullest extent that we can.
That's great. Thank you very much. I think I'll just finish off with just a few thoughts from me. In particular around urging people to, when they're thinking about what they can do next, because sometimes it can be quite frustrating, and you can get little small projects which get off the ground linking in with health, and then it doesn't get sustained and so on. I think we do have to reflect, though, that each of us can make a difference, and working together in our own individual way may be quite small in scope, but when we all come together, we do make a big difference to this topic. And we do save lives every year. And we've been talking about that from COVID, and I've been telling my teams in public health, this is real life-saving stuff. And the work that NEA and all the people on this conference do, it's saving people's lives and making their lives less miserable. I would urge you to get in touch with if you're not already, with your local public health teams based in local authorities, in all upper tier and unitary local authorities. And work with them, and they have lots of different skills and knowledge that they can help you with, not just in terms of data, but also in terms of links to wider partners. It's going to be interesting nationally, and I'll be working with NEA nationally to link in with the new public health structures of the UK Health Security Agency and the various bodies that are being established in relation to that. Get this on the agenda as early as possible so that we can make sure that those links in public health terms are made as early as possible. And then also the work that we can all do locally. We mentioned earlier on about integrated care systems. This is really, really important topic, an important way locally. And it might seem a bit of a mystery to a lot of people, and there's lots of talking shops and lots of discussions, but it's a real opportunity to build together those links between local authorities, between CCGs, between hospitals, between primary care, to think about what health outcomes together can be achieved and how we can really shift those pathways of care to put prevention right at the heart of it. We can all have a role in that. So I think the perspective I'd take is, how can you go along and support that and help those organizations to do the right thing, rather than what can we get out of them. And then there's I'm sure in most of them there would be an open door, and a seat at the table to be able to help support those and help support those place-based initiatives under the integrated care systems. That's been a really, really fascinating discussion. Thoroughly enjoyed it. I've learned a lot myself, and I hope people listening have got a lot out of that as well. So I just wanted to finish off by really thanking all the speakers and the organisers, and a real hope that next year we can get together in person and then continue the discussions in the bar with NEA afterwards. But for this year, that'll have to do that. So, and it's been really fantastic. And I can see there's still 109 people participating and watching this. So thank you to all of you for taking part and for posing questions and so on. And then just a reminder that tomorrow there will be an early morning session at 9:15 and the main plenary at 10 o'clock. Please come back. It's going to be another full and hopefully really productive day.